Thank you, Arup, for answering that question. The another challenging situation we normally face is the posterior polar cataracts. Would the surgery be little different than our routine cases? That is what we want to highlight here. We all know posterior polar cataracts, whenever you see, you have one thing in doubt: would this capsule retain its integrity till the end of surgery? That is a major concern for us. We know that incidence is quite low, but if you have a high volume practice, you keep on seeing these patients. And the rate of dehiscence can range from 8% to 30% in most of your cases. These are various types of posterior polar cataract you see. You have a reduplicated type of picture. Then this is a typical, normally seen posterior polar looking type of posterior subcapsular cataract, which will have a better orientation for surgery. Then you have this type of patient where definitive posterior defect may be there in your patients. Therefore, the initial examination of your patient is very, very critical for such cases. The size of the disc is important. Larger the size of the disc, more chances of posterior capsular dehiscence. And harder the cataract, more difficult the situations. So these two important things has to be seen before you take these patient examinations in your slit lamp. And subsequently, if you have access to ASOCT, in these cases you can do it. This is the intra-OCT for a posterior polar cataract, where we're trying to delineate the entire posterior capsule and the area of subcapsular cataract or a capsular adhesion or defect can be appreciated beforehand. So this can be seen by a routine entry segment OCT also, and that gives you a change in a plan in your surgery also. This is an endosurgery, well-placed surgery because PC was not defective. See, this is a patient where already there was a defect in the posterior capsule, not because of posterior polar, because of intravitreal injection. You can see the defect here. In such cases, you can really orient yourself and safeguard that particular point to not to let into a nucleus drop happening in these patients. The basic principle of surgery remains same as you do any phaco procedures. The only thing I would say is avoid hydrodissection in those cases where you feel the posterior capsule is compromised to begin with, or create a cushion of a posterior epicortical support so that till the end of your phacoemulsification it doesn't open up. Then subsequently take away this epicortex in a very smooth manner so that you decrease the chance of tearing the posterior capsule at that time. And the classically described slow motion layer by layer phaco is described in these patients. If you see this one classical video of posterior polar cataract, you can see a very nice center polar cataract of around 4 millimeter size. As I said, this is a smaller size, well described technique will be used. We are doing a capsular axis. You all know that capsular axis size should be adequate, around 4.5 to 5 millimeter desirable size. This I am saying because sometimes you may not have a support for posterior capsule towards the end, and you can put lens in the sulcus and get good optic capture happening in these patients. If you have a very large rhexis, sometimes that can be jeopardizing your sulcus fixation here. And rhexis should be complete. You can see very nicely doing complete. The second important step is to do a hydro procedure. Here we will be doing a hydro delineation. You've seen that I have removed the viscoelastic first so that we don't increase the pressure. Go deeper and increase this delineation. Avoid hydrodissection at this stage. You have second delineation happening. This is a softer nucleus. Most posterior polar cataracts will have a softer nucleus. Once you have a delineation, then subsequent emulsification has to be done. Make sure parameters are normal. 50 is my IOP. Normally I do a 55. Like people like Aware does in around 30 or 40 pressure IOP in these cases. Moderate aspiration and vacuum in these patients. Avoid if possible longitudinal phaco, just torsional will be enough. We are using a torsional system. And the central nucleus emulsification is very simple in these cases because soft nucleus. The challenge is to take out the peripheral cortex in these patients. You can see the cortex is now already lifted up. You just pull it towards the center and subsequently take it out. And this is a very, very important because towards the end of emulsification, the cortex gets loosened because of internal hydrodelineation happening. So this is the epicortex which is trying to pull up from each segment. Don't come to the center. Let the hydrodelineation happen. So this is a very important step. If you pull the entire segment, they can detach the posterior capsule from there. Allow the hydrodelineation to happen by segmental removal of epicortex. At this stage, remove your chopper. You can just aspirate with your aspiration tubing attached to the side port aspiration cannula without taking out the phaco handpiece also. So this hybrid technique safeguards your sudden decompression of antechamber. If you come out of during this time, the capsule can come up and you can have a posterior capsular defect happening at that stage. So the movement of surgery should be, the pressurized chamber should always be there before you do completion of phaco, before aspiration, before IOL implantation. So that ends the surgery, you can implant IOL subsequently in this case. What about if you have a little harder nucleus? This is a posterior polar cataract which has around grade 3 plus nucleus hardness. In those cases also, because we are not doing a hydrodissection, you have a difficulty in chopping and subsequent removal. I make a little trench, subsequently I'll chop it. You can the first chop, gives a space. Now rotation is not possible here. Take out another piece of nucleus which gives a space and internal delineation also. Once you take out this piece, take another piece from left hand side. So this, in the meantime, you have already got some delineation. Catapult this to the central area. The nucleus will come to center without disturbing the epicortical support from behind. So this is an important step in those cases where you could not get a hydrodissection properly. Sometimes it happens in a non-posterior polar cataract also where you don't have a good delineation or dissection. This technique should be used in those cases to give a space. What about femtosecond? Would this have an advantage? Yes, it can have an advantage. You can customize the nucleotomy. You can have a safety of rings, customize fragmentations, and epicortical customization can be done. And that we have reported in our techniques where we make various rings and nucleus chopping pattern in the hybrid technique. You can see here we do 3 delineation rings with the femtosecond laser and 3 chops. That gives us 6 fragmentation in a 3 segment wise, 3 layered segmentation, and subsequently you can take them out block by block. This is you can do a capsulotomy has been done. Subsequently, you're doing a nucleotomy in a hybrid technique. You can see 3 chops into 6, and you have 3 rings coming up in this particular case. And if you see in a emulsification phase, each piece can be separated without requiring a hydrodelineation or hydrodissection there. And the ease is very, very simple in these cases. And each block can be taken out safely, as you saw in the manual surgery also. Here you have segments there, or pieces there that can be taken out easily. You don't have to really chop to making smaller ones. So this is the advantage of femtosecond laser, and you leave the nice epicortex towards the end, and surgery can be completed very nicely in such cases. There have been few representative publication from Abhay also which says that you can create a safety of delineation rings in these cases, and results are quite okay. But what cases you like to do hydrodissection? There are people who do hydrodissection of posterior polar cataract also. This you saw earlier also. But if you can delineate the posterior capsule clearly from the nucleus, and the space is there, you can do a delineation here. Like in this particular case, I do a hydrodelineation first. Subsequently, I'll do a wave of hydrodissection because I knew that posterior capsule is intact. And once you do a hydrodissection, then surgery becomes simpler, and chances of posterior capsular dehiscence is also less. See this hydrodelineation wave, and subsequently surgery becomes important. Few complications can occur, especially posterior capsular dehiscence can occur. This is one of my patients, classical posterior polar cataract. Initial OCT, I could not delineate the posterior capsule here because the mass was too thick. And this patient had a very high risk of a posterior capsular opening. You can see towards the end of my phaco, and when I was trying to take out this epicortical mass, there was a linear opening which is normally seen in a posterior polar, which normally is an elliptical opening in these cases, unlike the creation of posterior capsular defect by your surgery, which is normally not linear. You can see a linear defect here, which will be more prominent subsequently if I magnify this. You can see this linear opening here. So this has to be maintained in such a manner and do a dry viscoaspiration cortex. Subsequently, you can implant lens in the back or in the sulcus depending on the support which you have in these cases. Similarly, if you have a patient where you can have thin posterior capsule, sometimes you can open up the bag towards the end of surgery also. This is after completion. I was trying to do a visco removal from behind the IOL, and that pressurized the posterior capsule, and posterior capsule open up. So you have to be very, very careful in such cases not to cause too much of significant changes happen. You can see a central opening here, and I could finish the surgery without any difficulties. So sometimes you can have despite doing a lot of good delineation, you leave a small tag in the posterior capsule. This was a younger patient with a posterior capsular tag was there. Like if you see here, you can see the posterior capsular mass which is there, like a PHPB type of case, where you may have to do a primary posterior capsular access to open up this clear area of posterior capsule to the end of surgeries, rather than waiting for a YAG capsulotomy in such patient, because there will be a little disturbance of anterior hyaloid face also. So this is a completion of rhexis. You can see around 4 millimeter rhexis being done in such cases. So these are a variety of situations you face in a posterior polar cataract. If you take a precaution of doing a very nicely guarded surgery and not compromising the posterior capsule in any stage of surgery, you're bound to have a good result in the posterior polar cataract also. Normally, the posterior capsular defects normally happen towards the end of surgery. If you see here our results, most of our PCR happen towards the end of surgery during cortex aspiration rather than nucleotomy phase. So don't think your surgery is completed nucleotomy. You can have complication towards the end of surgery also. I've seen one video from Dr. Abhay where he was hydrating the wound towards the end and the posterior capsule opened up. The surgery doesn't end in the posterior polar cataract. You have to be very, very careful. Thank you for kind listening.